incidence of Lyme disease, but it looks like it basically can occur throughout the state, but definitely some areas of high concentration. So this is just a table of the counties within Pennsylvania with the highest incidence of confirmed and probable Lyme disease cases. So you can see here the top 3 counties. There's a list by incidence, by descending incidence, but the top 3 counties are Cameron County, Jefferson County, and Clarion County. Here we have raw numbers, so this is not the number of cases per 100,000 population, it's just the raw number of cases occurring in each county in the year 2016. So you can see Butler County had the highest number of cases, followed by Montgomery County and Westmoreland County. A little bit more about the epidemiology of Lyme disease in general. The majority of cases occur in the summer months, so here you can see the number of cases reported by month of onset of disease. And again, in the spring and summer is when the nymphal ticks are most active and people are most often outdoors. So this makes sense, and we see these patterns with other vector-borne diseases as well. It's important to note that adult black-legged ticks do emerge in the fall, and they can be questing or looking for a blood meal through the fall and winter whenever the temperatures are at or above 40 degrees Fahrenheit. So it's important to know that cases can occur through the fall and even in the winter, especially for people who are outdoors and in wooded areas. This figure shows Lyme disease cases by age and sex. So you can see the male bars in blue and females are shown in yellow. And on the x-axis, you see increasing age. So Lyme disease affects people of all ages, as you can see, but there is a bimodal distribution. So you can see here that the highest rates occur in children under 15 years of age, and really especially 5 to 9 years, and especially males in that age group. And we think a lot of this, or all of it, is probably due, the differences between males and females, especially in children, is due to behavioral differences. Not to generalize too much, but boys are more so often in the woods and getting down in the leaf litter and in the plants and the brush, and probably are exposed to ticks more often, and so we see that increased incidence in Lyme disease in that age group, an increased number of cases. You can also see a bump, so kind of the second peak is in ages 35 to 55 years. And again, you see a slight male predilection there as well. So to summarize, any age group in endemic areas can become infected, but it's important to remember the highest risk groups so you can be aware of them. And of course, as pediatricians, for children, we need to be aware that children are one of the highest risk groups. So now on to the clinical aspects of Lyme disease. So this is a graphic of the signs and symptoms of Lyme disease in humans. So Lyme disease is characterized by 3 stages. So the first stage is the early localized stage, and that occurs within 1 month of the tick bite and the infection. So after a tick bite, Borrelia burgdorferi actually causes a local infection of the skin, and that often leads to erythema migrans that you can see here. So again, this is a local infection. So if you were to biopsy the skin and culture it, you could culture Borrelia burgdorferi from that specimen. And people can also have constitutional symptoms along with that: fatigue, chills, fever, headaches, some myalgias and arthralgias, and also some lymphadenopathy. If left untreated, the infection can progress and bacteria can disseminate throughout the blood and cause early disseminated Lyme disease. And this typically occurs 1 to 3 months after the infection. So some of the, I'll go into these in more detail in later slides, but some of the manifestations of early disseminated Lyme disease are facial palsy. People can get multiple EM rashes as the bacteria spreads throughout the skin, and people can also get meningitis and other manifestations. And then finally, if still left untreated, Lyme disease can progress to a late disseminated form. You can see arthritis is really the hallmark of late disseminated disease. Carditis is kind of on the cusp between early disseminated and late disseminated. It seems to happen actually a little earlier, on the earlier side, but it's important to be aware of. But other manifestations of late disseminated Lyme disease include neuropathy and other clinical findings, but arthritis is really the hallmark. But I want to underscore that these stages are really fluid. Patients can progress at different rates. and can progress to different signs based on their general predisposition or other manifestations. So it's good to be aware of all these possibilities. So the characteristic erythema migrans occurs in approximately 60 to 80% of cases, and it's usually accompanied, as I mentioned, by mild constitutional symptoms and occasionally by regional lymphadenopathy. It usually arises after an incubation period of 7 to 14 days. That's the typical, but it really can come up within a range of 3 to 30 days after infection. The rash extends gradually over days and can be warm to the touch, but it is rarely painful. The central clearing of the rash occurs later in the development of the rash, and so the bullseye characteristic appearance may not always be present. Patients can sometimes have local allergic reactions to a tick bite, and I'm sure many of you have seen this. Some features that help distinguish an allergic reaction to a tick bite from erythema migrans are allergic reactions are typically smaller, they are very itchy, they appear sooner, so basically within hours of the tick bite rather than within days of the tick bite, and they don't gradually expand over days like the erythema migrans rash does. I wanted to highlight other EM presentations. So it's important to note EM does not always present as the classic target lesion. So here on this slide on the left, you can see a very homogeneous appearance of erythema migrans. In the middle, you can see it has kind of a triangular shape, so they're not always perfectly circular or oval. And then on the right, you can see multiple erythema migrans rashes, and these are homogeneous as well. They can also vary in color. It can have a bluish hue. There can also be central induration or vesiculation, so sometimes it can be confused with cellulitis and other things. So it's important to keep in mind that even if it doesn't look like classic EM, it still could be Lyme disease. If left untreated, early localized Lyme disease or early localized infection can disseminate to other parts of the body, and this can cause multiple EMs and other manifestations. Facial palsy is one of the most common early disseminated signs of Lyme disease. It most often occurs in the summer months and can be bilateral. And if a lumbar puncture is performed, you can see pleocytosis in the CSF. Patients can get meningitis from Lyme disease, also arthritis, as I mentioned. It's intermittent and oligoarticular, it can be monoarticular. It's most often in the knees, but it can occur in other joints too. And one of the hallmarks of Lyme arthritis that many clinicians have described is that the swelling is out of proportion to pain. So people may come in with a very large and swollen knee, and it's hurting a little bit, but it's not that exquisite tenderness that you might see with a septic knee or some other things. And carditis typically causes, Lyme carditis typically leads to first, second, or third degree AV block and can be quite serious. Lyme carditis can actually be fatal, and I wanted to highlight this report that came out a few years ago. We were notified of some cases of young, otherwise healthy people who died suddenly, and the first case that we were made aware of, his heart tissues were being processed at an organ donation processing center, and a pathologist, a very astute pathologist who had worked in the Northeast and was now in a different part of the country but working at this processing center, noticed that the heart contained some perivascular inflammation that really reminded him of what he had seen in Lyme disease during his practice in the Northeast. And so additional testing was done. This was a young man who really died suddenly, and there was no indication of a previous diagnosis of an infection or any other reason why he would die suddenly. And it was actually found to be Lyme disease. And after this first case was recognized, we looked back on some other cases in partnership with some state and local health departments and also this organ processing center and others, and found other cases of people who had died suddenly, initially unknown why, but it turned out to be Lyme carditis. So very tragic and very scary. And really, we knew that Lyme carditis can be serious and can even be fatal, but we were surprised at the cases that we found and that this seemed to be happening more than we expected. Here is a tissue sample from one of the patients who died, and you can actually hear with the black arrow, you can see spirochete actually in the heart tissue. So the bacteria are there and are somehow disrupting the electric signals in the heart and causing AV blocks that can be fatal. There seemed to be a male predilection, and in this, so nearly all of the cases of fatal Lyme carditis that we have identified have been male, and we don't know the reasons for this. Other manifestations of Lyme disease, such as arthritis and meningitis, have specific patterns too, and so we wanted to look into this further so we can really help understand the pathophysiology and who's at risk for these various manifestations. So we did some research on disseminated Lyme disease. So we were able to look at insurance databases and using ICD-9 codes to identify the various manifestations of Lyme disease and compare those different populations and look at the patterns among those. So this is a table of patients from high incidence states, states with high incidence of Lyme disease, who were diagnosed with various manifestations of Lyme disease. So if you look at arthritis, here, you can see, so we looked at median age for all of these, and so arthritis really tended to be on the younger side. This is just median age, so it doesn't necessarily mean that people in their 20s were most likely, but in general, people seem to be younger when they're getting Lyme arthritis. And we also found an overall male predilection. So as I mentioned in the previous graph, there is a general male predilection for Lyme disease, but for these specific manifestations, there did again seem to be a male predilection. If you look at carditis here that I've circled, 71% of the cases we identified were male. We also subsetted this out to complete heart block, and that showed that 82% of those cases were male. So really some interesting stuff going on that we don't completely understand, but hopefully we can try to look into more and have a better understanding of the pathophysiology and other things. This is just a graph. When you look at the age and sex patterns together, this is a graph of odds ratios compared by age and sex to a reference group in the older age category. So when you look at this, so this first graph is specifically for arthritis. So you can see males, and particularly young males, have a much higher odds of having Lyme arthritis compared to patients with disseminated Lyme disease. And also females as well. Young females do have a predilection, but it wasn't quite as strong as for the males. And then here you can see carditis graph. And so, again, you can see that really strong male predilection. Conversely, females seem to have some protective effect, but males in the 15 to 25 age group really do seem to be the highest risk for Lyme carditis. So keep that in mind when you're seeing patients, and if you have patients who are complaining of palpitations or other things and you don't have a good reason for, try to think of Lyme disease and evaluate for that if you think it's possible. So for diagnosis of Lyme disease, the diagnosis is based on clinical presentation and potential exposure to black-legged ticks in an area where Lyme disease is endemic. Diagnostic testing is based on serology, and it's a two-tiered approach that's recommended using FDA-approved tests. And I will go into detail on this in the next slides. In endemic areas, testing is not needed for early Lyme disease if patients present with a single erythema migrans rash. So if they have the risk factors, if they've been outdoors, maybe they found a tick, they have erythema migrans rash, and you're in Pennsylvania where it's known to be endemic, Lyme disease can be diagnosed clinically. And part of the reason for this is because the erythema migrans rash is very specific. There is now a mimicking condition, which I'll talk about later, but it's very specific, and the antibodies on serologic testing may not be detectable for 2 to 3 weeks. So if you test too early, the immune response has not fully developed, and so it may not be detectable by diagnostic testing. So that's why in early Lyme disease, it can be diagnosed clinically. However, for disseminated infections, illness without EM rash, later infections, it's important to confirm the diagnosis with diagnostic testing. So CDC recommends a two-tiered approach for serologic testing. So here you can see on the left side of this diagram, and this diagram is actually available on the CDC website if you want to print it or save it or put it up in your office. So the first test most commonly is an EIA, enzyme immunoassay. IFA can be done, but it's not very common. If that first test is positive or equivocal, it should be followed up with the second test you can see here on the right, which is a Western blot. If the patient has been sick for less than or equal to 30 days, you should order and interpret both the IgM and IgG. However, if the patient has been sick for more than 30 days, IgG is likely to be positive by then, so that is sufficient for diagnosis in the vast majority of cases. During this time, IgM can cross-react and cause false positives. And because IgG should be sufficient during this time, we recommend that people only interpret the IgG Western blot. If you can only order it, that is ideal. But if it comes back, a lot of labs automatically do both IgM and IgG. It's important to know if someone has been ill for some time, more than a month, that the IgG Western blot is what should be interpreted. We get a lot of questions from providers and patients with confusion about the IgM testing and the results and potential false positives about that. So really focus on the IgG. The sensitivity of two-tiered testing really depends on the stage of disease. So like I said, early in Lyme disease, there's that window period, which is true for all serologic tests. And so the sensitivity is more on the order of 38% around there. So it's on the lower side. But as the infection progresses and the immune response progresses, the sensitivity of serologic testing improves vastly. We will see cases of patients with Lyme arthritis, and they really have a strong immune response. In the later stages of infection, serologic testing is very good. There's 10 bands that are looked for on IgG. Many of you have seen this on reports. And we'll see patients with 8, 9, or 10 bands on Western blot. So really there's no question for patients who are truly infected long-term and in these late stages, they usually have highly positive tests, and it's easy to say that that's the reason for their symptoms. The specificity of two-tier testing is generally greater than 95%. You will sometimes hear people say, oh, this test, Lyme disease serology misses 50% of all cases, and that's really an oversimplification. That's basically averaging the sensitivity for all these stages without taking into account that window period and the understanding that we expect the sensitivity to be low in the early stages of disease. So we wouldn't recommend people using this quote or saying this to others because it really is kind of a misrepresentation of the sensitivity when you lump it all together. So other tests for Lyme disease, there are PCR tests available through some commercial laboratories, but they are not FDA cleared. These tests are currently considering the adjunct tests. They're not really recommended for routine diagnostics. They're not generally useful because in the blood there are few organisms and they're just in the blood transiently. So even with a sensitive test like PCR, it can be difficult to detect even if patients are infected. The advantage is that it's not, of course, dependent on antibody development. The disadvantage is that even though it's PCR, it can be insensitive, and blood specimens are positive in only about 50% of acute cases with erythema migrans. PCR testing of the synovial fluid in some cases in patients with Lyme arthritis and a diagnostic dilemma can be useful, though. So another type of direct detection method is culture. Culture has moderate sensitivity. It has been used for blood in the first 2 to 3 weeks of infection. It can also be used for skin biopsies. We don't recommend this as a regular test. Of course, it's invasive, but it has been used in some cases for patients with atypical rashes or maybe no history of exposure, basically patients with diagnostic dilemmas, or for research when they're enrolling patients for trials and they really need to know that they truly have the Borrelia burgdorferi infection. Culture has low sensitivity. It's sometimes used in the CSF and synovial fluid, but overall it's labor intensive, the spirochetes grow slowly, and it can be expensive to process these. So it's not generally used as an everyday clinical test. So CDC recommends that healthcare providers use tests that have been evaluated and cleared by FDA. However, some laboratories offer Lyme disease testing that has not been adequately validated. And these include single-tier Western blots without a previous EIA. Sometimes people order these either by mistake or it's offered by certain labs just to go straight to the Western blot. And some people incorrectly may have heard misinformation that going straight to the Western blot is more accurate, but that is not the case. So we really recommend sticking with that two-step or two-tier approach. Some labs use their own criteria for interpretation of Western blots. So for IgM, it's recommended that 2 out of 3 bands is the cutoff for positivity. They look for 3 bands, and if patients have at least 2 bands, then that's considered positive. For IgG, it's 5 out of 10 bands. They test for 10 bands, and 5 or more bands present is considered positive. But unfortunately, some other labs use their own criteria with fewer band requirements, and that has not been sufficiently validated and is not recommended by CDC. There's other tests out there that are offered, capture assays for antigens in the urine, tests for so-called cystic forms of Borrelia burgdorferi, lymphocyte transformation tests, CD57 assays, and also some novel culture techniques that some companies have claimed to develop and offer to patients. I just wanted to say a note also about CLIA approval. CLIA is the Clinical Laboratory Improvement Amendments Act. And CLIA approval is necessary for labs that process human samples for diagnostic testing. It makes sure that their equipment is accurate, they have record-keeping standards, and other things are appropriate in terms of the lab and how they handle specimens. So it's necessary, but it's not sufficient to demonstrate that a specific test is clinically validated. So labs will advertise that they're CLIA approved. That really is assessing the laboratory in general, but not the clinical validity of a specific test. So just because a laboratory is CLIA approved does not mean that the specific test they are using is accurate for that patient population. If you have questions, if patients have questions about what test to use, or if they come in with a printout of test results and you're not sure if this is a valid test, feel free to reach out to an infectious disease doctor for consultation, or also feel free to reach out to CDC. You can call 1-800-CDC-INFO and get routed to the Division of Vector-Borne Diseases, and we're happy to answer questions about that. So Lyme disease is treatable with antibiotics. The recommended regimens range from 10 days to 4 weeks, orally or IV, and that really depends on the stage of illness. Most patients treated with antibiotics recover completely, although it can take some time. It's not unusual for a patient to really just feel run down for days to weeks after treatment, and they eventually typically recover, but it's helpful to counsel patients about that they've had this infection. It can really, it really runs the gamut with your body, and your body can take some time. It doesn't mean that you're necessarily still infected or need additional treatment. Your body just needs some time to recover. In patients with persistent or recurrent joint swelling, retreatment with a second 4-week course of antibiotics may be needed and is included in the guidelines. So here's the recommended therapy for patients with early Lyme disease. This is also published on our website, and you can find it in other publications. So for adults, doxycycline is the mainstay of treatment, but there are other options, cefuroxime and amoxicillin, I'm sure many of you have used for treating Lyme disease. And for children, amoxicillin, doxycycline are the most common regimens given, and cefuroxime is also a good alternative. So here's a list of references. For more information, I really encourage you to check out these resources. They have detailed information about treatment and other information. I think you all have gotten or will get copies of these slides, so feel free to refer to these references. They really are helpful for clinicians. So in terms of prognosis, most patients treated with antibiotics recover completely, although as I mentioned, it can take some time. Some patients, particularly those who have been diagnosed with later stages of diseases, can have persistent symptoms of fatigue, muscle aches, reduced concentration, and the preferred term for this is post-treatment Lyme disease syndrome, PTLDS. And the exact cause of PTLDS is not yet known, Most experts believe that the lingering symptoms are the result of residual damage to tissues that perhaps occurred during the acute infection. It could also be an autoimmune response after infection. However, some healthcare providers tell patients that these symptoms reflect persistent infection with Borrelia burgdorferi, but this has not been proven to be the case. Regardless of the cause of PTLDS, studies have not shown that patients who receive prolonged courses of antibiotics do better in the long run compared to patients treated with placebo. And unfortunately, death and serious injury have occurred as a result of some of these non-standard treatments. So I'll briefly mention the term chronic Lyme disease. It has been used to describe people with various illnesses. Sometimes it's used to describe illness in patients with a history of documented Lyme disease, for example, patients with PTLDS. However, it's also been used to describe symptoms in people who have no evidence of a current or past infection with Borrelia burgdorferi. This includes people with nonspecific symptoms but no objective signs of infection. And due to confusion in how the term chronic Lyme disease is employed, experts in this field do not support its use. For more information, then NIH has information on chronic Lyme disease on its webpage, so feel free to check that out. But again, I want to mention in multiple placebo-controlled studies, there has been no sustained benefit observed following prolonged antibiotic treatment. In fact, there have been many instances where people have instead been harmed by prolonged therapy. So some of these adverse outcomes from alternative treatments or extended treatments for Lyme disease include biliary complications, biliary sludging, sometimes resulting in gallbladder removal, hemolytic anemia from ceftriaxone, C. diff infections for sure, fatal sepsis, and also one patient developed, had an indwelling catheter and developed a thrombus on the tip of that catheter, which broke off and went to another part of the body and caused death because that catheter was in for so long for prolonged treatment. So I really want to underscore that these treatments can be dangerous. There's a couple of references at the bottom that you can refer to as well. The first reference talks about the gamut of unorthodox treatments that are marketed to treat Lyme disease. There are really a lot of different treatments offered to patients that have not been shown to be beneficial. And also a case series of patients who acquired serious bacterial infections during treatment for what they were told was chronic Lyme disease. This was just a case series. We weren't trying to calculate absolute risk or other things, but this was just highlighting the potential adverse effects of these treatments so people can be aware of the risk. So some updates on other tick-borne diseases. Other diseases spread by black-legged ticks include anaplasmosis, babesiosis, Powassan virus infection that's been in the news in the past year, can be very serious and even fatal, and ehrlichiosis, also known as Ehrlichia murus occlurensis or Ehrlichia murus-like agent. The mnemonic I use, the main diseases spread by black-legged ticks, or the most common, are Lyme disease, anaplasmosis, and babesiosis, and so I like to use the mnemonic LAB, so Lyme, anaplasmosis, and babesiosis, LAB. That helps you remember the most common diseases spread by black-legged ticks. Anaplasmosis, fortunately, is treatable with doxycycline. So if a patient does have a co-infection, or if you think it's a tick-borne disease, you're not sure if it's Lyme disease or something else, treating with doxycycline will cover both of those. On the other hand, babesiosis, however, is a parasite and requires different treatment, so will not be treated by a course of doxycycline. Something that's been in the medical news and literature lately is Borrelia miyamotoi. Again, it's a relapsing fever spirochete, so it's kind of a different family from Borrelia burgdorferi and the species that cause Lyme disease. It was first recognized in Japan. The first report of human infection in the U.S. was not until 2013. Tick surveys have shown that it's present in approximately 2% of Ixodes ticks in the United States in certain areas, but that can be up to 10.5% in specific areas of the country. Most patients who have this experience fever, headache, myalgia, malaise, arthralgia, and rash. Rash is uncommon. the case series and the reports have mostly been done in the Northeast, so areas like Boston and other areas around there. So Pennsylvania, I'm not aware of specific cases that have come out from Pennsylvania, but I wouldn't be surprised if it is there or maybe there soon. So patient with a tick bite, outdoor exposures, having relapsing fevers and other symptoms, but not necessarily a characteristic rash. Good to think about Borrelia miyamotoi and a relapsing fever. There is no test for Borrelia miyamotoi. There are serologic assays and PCR that are offered by a limited number of CLIA-approved laboratories. So this is one case. I mentioned CLIA-approved laboratories before. Necessary for laboratories that process human samples. And this is one case because the disease is so new, we would have to go with a non-FDA approved test just because many tests are in development or potentially in the process of FDA clearance, but that hasn't happened yet. Lyme disease, on the other hand, has been around for a long time, and there are FDA approved tests for that, so we would recommend going with that. And fortunately, the treatment is it can be treated with the same antibiotics that's used for Lyme disease. It seems to, although the number of cases is small so far, we're still learning about it, that antibiotics seem to be effective, so that's good. So another tick-borne disease is that complicates the diagnosis of Lyme disease is SARI, Southern Tick-Associated Rash Illness. It's transmitted by the lone star tick, which is shown here, and you can see the adult female has a characteristic white spot on her back, hence the name lone star tick. It's predominantly in the southeast United States, but the range is expanding and now includes Pennsylvania. So these can be found in Pennsylvania, and they are aggressive human biters, and so they can bite humans and occasionally cause SARI. SARI complicates the diagnosis because the rash is indistinguishable from the Lyme disease erythema migrans. So in areas where you only have one tick, if you only have black-legged ticks or you only have lone star ticks, then if you see a bullseye rash or erythema migrans like rash, then you can be confident that it's either Lyme disease or SARI, depending on where you are. But in areas in the mid-Atlantic, including Pennsylvania, where both ticks exist, sometimes it can be confusing what a patient has. SARI can be accompanied by fever, fatigue, headaches, and muscle and joint pains. It follows the bite of a lone star tick, as I mentioned. It's also known as master's disease, and the cause is really unknown. They've tested for many pathogens, bacteria, viruses, other pathogens, and have not found an infectious cause of SARI. It's important to note, though, that lone star ticks do not transmit Borrelia burgdorferi. It's been shown, actually, that their saliva kills Borrelia. So if a patient has been bitten by a lone star tick, it's clear that they don't have Lyme disease unless they were bitten by another tick, and that it's likely SARI. But we still don't know the cause for it. The treatment of SARI, it's not known whether antibiotic treatment is necessary or beneficial for patients with SARI. SARI has not been linked to arthritis or neurologic disease or other long-term symptoms after the condition. And in fact, there are no known sequelae of untreated SARI, fortunately. But because SARI resembles early Lyme disease, physicians will often treat patients with oral antibiotics to cover for both possibilities. So for prevention of Lyme disease, I wanted to talk first about repellents, important for prevention of Lyme disease, but also other infections, mosquito-borne infections, and other things. So repellents are very important and very helpful in terms of preventing bites from arthropods and other things that can attack people. So DEET is used by many people. It's been used for decades. It's safe and it's effective. The AAP recommends that DEET can be used on children aged 2 months and up. So the AAP has assessed the safety as well and efficacy and does recommend DEET for children. The higher the concentration, the longer it lasts. And that's true for up to 50% DEET. After 50%, you don't get much of a benefit in terms of how long it lasts. So we recommend, and AAP recommends 10 to 30% DEET for children. So if you know a child's going to be out for just an hour or so, 10% is fine. If you want longer coverage, then you can use a higher percentage. There are other options. Again, DEET's been around for a long time. It is safe, but there are other options for people who may be interested in not using DEET. So picaridin is another really good option for a repellent. I use DEET on my children. I also have used picaridin, oil of lemon, eucalyptus, which I'll mention. And I actually really like picaridin a lot. It's not very greasy, and it doesn't have a bad odor. It kind of has a nice smell to it. So that's a really good option if you're talking to families who want other options for repellents. And oil of lemon eucalyptus is another good option, and it's good for people who may want a more natural alternative, but something that's still effective. It has been shown to be effective, but it's only for children aged 3 years or older, so that's the one caveat to remember. But after 3 years, it's a very good alternative. IR3535 is another one. It's not on this slide, but it's another repellent that's effective and can be used. It's important to apply repellents and counsel your families about applying them outdoors so you're not breathing in the spray. And for young children, since they suck on their hands and they often put their hands in their mouth, try to avoid putting the repellent on their hands. Don't spray it directly on the face. We recommend an adult spraying on their hands and then wiping it on the face. And then when kids come inside, if possible, washing or wiping off the repellent after use. Of course, if you're camping or doing other things, that's not possible, but if you can, we recommend that. The website that you see here is a very useful tool. It's an EPA tool, and so you can go on and search by how long you want coverage or who you want to cover, whether it be children or adults, and whether you want coverage for ticks or mosquitoes or both. And you can find different options for repellents that are right for you. And so it's user-friendly and it's really helpful. So I would recommend checking it out and also directing your patients and your families towards this website if they have questions about it. The AAP also has some very helpful information about repellents. They put out their AAP Parents Plus. I know many of you are familiar with information about various things, but they do have some good ones about repellents, so that's good to use as well. Permethrin-treated clothing is also another great option. So permethrin is a repellent, and it lasts for many washes. And so if you have a pair of hiking pants or gardening pants or gardening shirt or camping pants and shirt for your kids, then you can apply permethrin. You can either buy clothing that's already impregnated with permethrin, or you can buy permethrin and treat your own clothes and socks and other things. And like I said, it lasts many washes, and it's effective, so we would recommend using that as well. And it's really easy to use, of course, because it's just part of the clothing. I would really strongly recommend avoiding other herbal or natural repellents that have not been shown to be effective. There's a lot of stuff on the shelves that promises to be natural and repel insects, mosquitoes, ticks, other things, but are not effective and really are a problem because they don't have demonstrated efficacy, and people get a false sense of safety from using these things. So really recommend, if people have questions, looking up to see if there is safety data, and also possibly going to the EPA website or the AP Parents Plus to see if what you're wanting to use is effective. If it's not, choose one of the other things that's listed on this slide. So some more prevention tips. After being outdoors, put clothes in the dryer on high heat for 5 to 10 minutes. So we found that kills ticks. A lot of ticks can come in hitchhiking on your clothing but haven't attached yet. So if you just throw them in the dryer on high heat, we did some studies and found that will kill black-legged ticks after just 5 to 10 minutes. If your clothing is soiled and you don't want to put it straight in the dryer, then wash it on hot water. Showering within 2 hours is also effective in preventing tick-borne diseases. It washes away unseen nymphs and helps people get undressed so they can do their tick checks. Tick checks, again, it's important to do every day if possible and after you've been in outdoors in wooded areas. And that really helps you find and remove the attached ticks as soon as possible. Like I said, it takes at least 36 hours for Borrelia burgdorferi to be transmitted. So if you can find those ticks and get them off as soon as possible, you can really reduce your risk for Lyme disease. For other conditions like Rocky Mountain spotted fever and anaplasmosis, the bacteria can actually be transmitted sooner. So that doesn't apply for all tick-borne diseases, but for Lyme disease, it's very helpful. And then treating pets appropriately for ticks year-round. So some research suggests that pets bring in ticks and actually can increase risk to owners. Pets have many advantages, and we certainly support people having pets, but they can bring in ticks and put their owners at risk. And so it's important to treat pets for ticks and talk to veterinarians about how best to do that, and to do it year-round, not just during the warm months. So preventing ticks in the yard, just briefly, you can find this on our website. I just wanted to mention that black-legged ticks really like moist, covered, unexposed areas. Otherwise, if they're out in exposed areas and heat and sunlight, they can desiccate. So to prevent Lyme disease, it can be helpful to create a barrier around your yard of mulch or other things that ticks don't like to be in and don't like to cross. And so if you have a wooded area and you can have this mulch or wood chip barrier, then that makes the inner area safer. And so things like playgrounds and gardens and other things you can hopefully have more towards the center within that barrier area. Also, not having things where white-footed mice and ticks like to be like wood piles, trying to keep those either away from your house and clean, and if you do have them, just trying to keep them in that barrier area or somewhere that's not close to playgrounds and other things. So one question that comes up a lot is about tick bite prophylaxis. A single dose of doxycycline may be offered to patients over 8 years of age to prevent Lyme disease, provided certain conditions are met. So if the patient did find an engorged Ixodes scapularis tick, it works because that indicates the tick was attached long enough to transmit the infection, or if by history they're pretty sure when they acquired the tick, if they know they were out hiking and got it then you can say that they had it long enough. Prophylaxis can be started within 72 hours of tick removal, and the local rate of tick infection with Borrelia burgdorferi is high. The guidelines say at least 20%. This information, of course, the infection rate of ticks in your area is not always available, but really just we say if it's a highly endemic area, which most parts of Pennsylvania are, then it fits the criteria. Tick bite prophylaxis is not recommended to prevent other tick-borne diseases such as anaplasmosis, ehrlichiosis, or Rocky Mountain spotted fever. There's not enough evidence out there to show that it's effective, and it may actually just mask or delay the symptoms, so it's not currently recommended. I wanted to briefly mention a Lyme vaccine. Many of you may know that Lymerix was available for humans as a Lyme vaccine, but was removed from the market in 2002. But there are some Lyme disease vaccines currently in development. There's an OSPA vaccine. So OSPA is an outer surface protein, OSP, that's expressed by Borrelia, the bacteria in the tick. So the vaccine would actually help the body kill Borrelia burgdorferi right as the tick attaches. There's also some other chimeric vaccines with both OSPA and OSP, and that's actually licensed. Some of those are licensed for dogs in 2016 and could potentially be used for humans in the future. There's also some studies that have come out on passive immunity you may have seen in the medical news. This is basically an infusion of antibodies every year. It would have to be done every year in the spring before people are most likely to be exposed, but seems to be able to protect people from Lyme disease. So that may be an option in the future. So I wanted to just finish up with by highlighting some resources that you may find useful in your practice. So if you go to cdc.gov/Lyme, and then you go to the section for healthcare providers, you can find a lot of hopefully useful materials. So one thing that's been very popular is a reference manual on tick-borne diseases in the United States. You can download the PDF online, where I showed you, just go to healthcare providers, or you can order hard copies. They're absolutely free. And that includes information on tick identification, maps, symptoms of the various tick-borne diseases, treatment for a lot of different tick-borne diseases, and also references and more information about prevention. Just some things that are included in the tick-borne disease manual and why many people have found it so useful. So there's pictures of 9 different ticks. So if a patient comes in with a tick, you can refer to this and try to figure out which one it is, which can help you narrow down which diseases they may be at risk for. It also has information on the geographic distribution of all these different ticks, and of course the pathogens that they can carry. And then there's pictures of the different ticks, as you can see here. And then also a picture of an engorged tick. There's some confusion actually once a tick is engorged. It's harder to identify which type of tick, of course, but also some people actually confuse it with a watermelon seed or aren't sure what exactly it is, so we included that picture for references as well. And so you can see here, hopefully you can read this, but there's lots of different tick-borne diseases here, and as I mentioned, all with information on symptoms, how to diagnose, and how to treat all of those tick-borne diseases that are included. We also have a section highlighting in the manual atypical erythema migrans, so pictures of, like I mentioned, the bluish hue or homogeneous rashes and other things. And we also have a picture of an allergic reaction for a comparison that's not an erythema migrans. On our website, we also have some educational videos. Usually they're between 4 and 7 or 8 minutes in length, so they're pretty short and talk about specific things related to Lyme disease testing or Lyme carditis or other things. So people have found these very useful. We've gotten good feedback, and so if you want more information, feel free to check it out. So again, going back to cdc.gov/Lyme, if you click on, instead of healthcare providers, educational materials, you can get some communication materials and things for your patients as well. So we have brochures about Lyme disease. We have fact sheets, including a fact sheet for parents about Lyme disease. There's also a trail sign and some radio PSAs that you could maybe download or put on your website. Those are available for free. You can order trail signs if you want to put them up in your area. And then we also have a whole slew of things for Lyme disease prevention for kids. So if you want to order these or print them out and put them in your office, feel free to do that. There's a crossword puzzle and there's an information sheet for kids that highlights prevention and other things. And also one of our most popular things has been these Lyme disease prevention bookmarks. So you can see an example here talking about how to prevent tick-borne diseases wearing repellent, showering soon within 2 hours of coming outdoors and other things. And on the back, it shows how to remove a tick with instructions. I know there's a lot of folklore about how to best remove a tick, but this on the back of the bookmark, it just has really simple instructions about how to do it with gentle, firm upward pressure, and you don't need to use other things. So that's all I have. Thank you again very much for your attention, and I will give it back to Eileen.
Thank you, Dr. Nelson. That was fantastic. Jane, if you don't mind jumping on right now for the Q&A.
At this time, I would like to remind everyone, in order to ask a question, press star and the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Dr. Nelson, we do have a question online that says, can EM rash appear?
Can EM rash appear?
Yes, that's what it says.
Let's see. I'm not sure I understand the question. Let me see if I can look if there's more. Yeah, I'm not sure exactly what the question is. If the person asking it could clarify, I'd be happy to answer. Okay,
yes,
I see another question.
Here, but this is Renee Turchi. I had a question. It looks like mine got cut off somewhere. But I was wondering, Dr. Nelson, I just want to say first, thank you for an excellent webinar. I learned a lot. I was wondering about your thoughts on, the prophylaxis. So are there certain labs you recommend, it's sort of a two-part question, certain labs you recommend to send the ticks off to confirm confirmation in the tick? Because I think often then, so just making sure we send it to legitimate labs, but you have to prophylax within 72 hours, so sometimes you're faced with actually deciding to prophylax before you actually get confirmation that the tick is actually infected. So I guess it's helpful to just prophylax if you have a high index of suspicion, or if you're in particularly one of the counties that you indicated. Just wondering if you could weigh in on that, A, on the lab efficacy, and 2, on just the time delay from confirming tick infection with deciding to prophylax a patient.
Yeah, thanks, Dr. Turchi. That's a very good question. And I'll mention that I can now see the full questions that other people type. So after I answer this question, I'll make sure to get to the other questions that I see there. So generally speaking, we don't usually recommend tick testing, and it's for a variety of reasons, including what you mentioned, Dr. Turchi, is that typically you don't get the results in the amount of time that you need to make clinical decisions. And so there's really not much, we would encourage people to make their clinical decisions based on other information and treating presumptively if you need to, or ordering testing without waiting for the test results from the ticks. And there's other reasons. In general, if you get a positive result, you can't necessarily be sure that the patient was infected. Maybe the tick just carried the bacteria but wasn't necessarily attached long enough to infect the patient. And so a positive result can cause concern, but without a clinical correlation, it's hard to say if the patient's actually infected. And then conversely, if the tick is negative, sometimes that can cause a false sense of security, because if that particular tick was pulled off and was tested negative, it doesn't necessarily mean that the patient, they were outdoors and in enough time to get that one tick, and so they might have gotten another tick that could have been infected with Borrelia burgdorferi or other pathogens. So yeah, like I said, generally it's not recommended, but I know some people are still very interested in it, but we don't necessarily have certain labs that we would recommend. I would just make sure, if you do want to pursue that, to check out their website and ask very specific questions about how they're doing the testing and what's their clinical validation and other things. Did I answer your question?
Yes, thank you very much.
Okay, so the EM rash, so it looks like, can the EM rash appear anywhere on the body or only at the site of the tick bite? So for the initial EM rash, it occurs at the site of the tick bite, because that's where the bacteria have entered the skin and are starting to multiply and spread and create that erythema migrans rash. So early on, the first EM rash, that is at the site of the tick bite. Later on, however, if left untreated, the bacteria can disseminate through the body and cause multiple EM rashes, and those can be all over the body. So don't necessarily have to be at the site of the tick bite. And then another question I see, does tumbling clothes in the dryer work to kill other species of ticks as well? That is an excellent question and something that we're looking at. So we initially tested black-legged ticks, and that's where we found that 5 to 10 minutes was sufficient for those species, for that particular species. But lone star ticks are actually much more resistant to heat and desiccation, and so we wanted to test those as well, because, as I mentioned, they're aggressive human biters. So we haven't finished that testing or published it, but the good news is it's looking like 5 to 10 minutes is actually sufficient for lone star ticks as well, but that's just preliminary information. I don't see any other questions online. I'm happy to take other questions through the phone.
There are no questions at this time over the phone. You may continue.
Hi, Dr. Nelson. This is Eileen. There's been some news. Hi. There's been some news lately of the red meat allergy and its relationship to the tick bite. Is there any truth in this? And if so, can you give us some more information?
Yeah, thanks. So yes, interestingly, some of you may have heard about this on the news, and it's fascinating that, yes, some people have developed red meat allergy, and although a definitive link has not been proven, it looks very likely, based on the research that's out there, that it can actually be caused by the bite of the lone star tick. It may be something in the saliva that mimics the proteins in red meat, and after repeated exposure, people become sensitized after getting the lone star tick bites and then have this allergy to red meat. So it is a true entity. It is seemingly associated to lone star tick bites, unfortunately, and can actually be pretty severe and life-threatening. So it's been discovered more in the South. Lone star ticks are more common there, and so people more often get bitten. A little less common in Pennsylvania, but as I showed you on the map, they can be present there, or if you have patients who have moved from the Southeast. The interesting thing about the red meat allergy is actually it can be a little hard to diagnose, because it doesn't happen, the symptoms don't happen right away when people first ingest the meat. It's only once the meat is digested and the proteins are changed a little bit and exposed that people start to have symptoms. So the classic cases are people who go to a barbecue at night, in the evening for dinner, and then they wake up at 2 in the morning and they have pretty severe symptoms of anaphylaxis. Their stomach's hurting, their throat's tightening, they have hives, and so that delay in the time period sometimes can make it hard to nail down what actually caused that. But taking a good history and really asking people about red meat and other exposures is important. But as I mentioned, it can be life-threatening. Some people have had pretty severe anaphylactic reactions to it. So it's good to be aware of, and if you have patients coming in with strange allergy-type symptoms that are happening at strange times that you can't pinpoint, it's worth looking into.
This is Renee again, Dr. Nelson. I had another question, and I'm like, you know, I'm sure you get this a lot, but I'm just wondering, as it's happened to me a couple of times, and I don't know about other folks on the line, but you know, you touched on chronic Lyme disease, and it just seems like there is, you know, I've had one patient in the past whose parents were, you know, going to a clinician who was, you know, they were diagnosed with chronic Lyme, and the parents were paying lots of out-of-pocket dollars for, you know, it really was not as much about chronic antibiotic therapy, but they were doing all these, you know, herbal and vitamin supplements, and it seemed like it was pretty costly. And, you know, I was able to convince the parents to see a colleague of mine at Children's Hospital on infectious diseases. But, you know, I just wonder, I mean, I imagine that you hear this a lot. It seems like sometimes chronic Lyme can be sort of this catch-all for, you know, some other, you know, undiagnosed illnesses. And I just wonder, you know, I mean, in my case, that was what I sort of chose to do, and I'm fortunate that I'm in an urban area where I had, you know, access to infectious disease clinicians that could help debunk that this was, in fact, not chronic Lyme. But I'm sensitive to the fact that many of our practices across Pennsylvania, you know, they have families that aren't as, you know, the access to, you know, infectious disease clinicians that do things as an outpatient is not as easy. So they may find themselves at times, you know, trying to deal with these things. And I just wonder if you have any thoughts on that.
Yeah, thanks for bringing that up. Those situations do occur, and yeah, people can be exposed to pretty substantial treatments that have not been shown to be effective, and as I mentioned, can be dangerous. And I think that's, in many cases, that's where these laboratory tests come in that have not been clinically validated, because patients may see a doctor who tells them that they have chronic Lyme disease and then sends their blood off to one of these laboratories that, you know, seems to support that diagnosis, but they're not using tests that are clinically validated. So it's kind of supporting something but not using good information to support that. So yeah, I mean, it's tough. I mean, I think trying to do some preemptive counseling about, you know, there's a lot of information on the internet, you know, related to lots of different health conditions, but especially for Lyme disease, that's not particularly accurate. And so if you have a patient who's just diagnosed with Lyme disease, or just maybe looking for answers for a condition that's unexplained up to that point, just really helping them understand that there's a lot of information out there that may be misleading, and trying to funnel them towards trusted websites like cdc.gov and the American Lyme Disease Foundation. Hopefully that can help in getting people good information. And in terms of finding out what's actually going on and maybe referring out, definitely I understand it can certainly be hard for patients to get a second opinion, or to find an infectious disease doctor to consult with if they're not in an area that allows access to that. So in those cases, I would really just try to help highlight for your patients that that treatments have not been proven to be effective, and they can be dangerous. And also, really, we've also had some cases of patients who have had another condition that actually went undiagnosed because they had been told that it was chronic Lyme disease that was causing their symptoms, and they were receiving treatment for that. So they were kind of led down the wrong path and lost time in treating their actual condition because they were told they had chronic Lyme disease. So I think really trying to help families and your patients understand that even though you may have been told that this is what you have and it's the cause of your symptom, let's step back and look at the evidence for that, and why you are being told that you have this, and really making sure that there's nothing else causing your symptoms that we don't want to miss. And so I know these are really tough situations sometimes, but just trying to understand where the patient's coming from and trying to lead them down a good path that's not going to actually cause harm are the best things that the primary care providers can do.
Thank you. That was great. I think there's another question there, Dr. Nelson. Are you able to see that?
Oh, yeah. So the one about prophylactic meds in a child under 8? Yeah, so that's a really good question. So the question is, can you discuss prophylactic meds in a child under 8 years? We've been told in this scenario that doxy would be okay. So yes, really good question. We get this question from pediatricians a lot. What do you do in a child who's under 8 because doxycycline is not recommended due to the concern for tooth staining? So it's possible to prophylax with a full course of amoxicillin. Because of the half-life differences, you can't use amoxicillin as you would in a single dose like you would doxy. So in a child under 8, they would need the full course of amoxicillin. And there's been some analyses, and the experts basically found that if you were to do that for routine prophylaxis, that the risks of those full courses of amoxicillin would outweigh the benefits you'd get from preventing Lyme disease. So unfortunately, I just wanted to mention that. I know it's not part of the question, but that's the option that has been considered most for children under 8. In terms of doxy for children under 8, so, I think we all learned in medical school, and there's concern about the tooth staining, and so that's why it's not recommended. In terms of Rocky Mountain spotted fever, it is the recommended treatment, and some of my colleagues at CDC have done research on the tooth staining for children who have received multiple courses of doxy for Rocky Mountain spotted fever, and that has not shown an increased risk in tooth staining. And so for Rocky Mountain spotted fever specifically, always the recommendation has been use doxycycline in any age, but if you're thinking of Rocky Mountain spotted fever and you're concerned about it, the message that they want to get across is go ahead and treat with doxycycline. Don't worry about the tooth staining because Rocky Mountain spotted fever can be fatal. We have not put out guidelines that, in light of this new research on tooth staining, we have not put out guidelines, or others that I'm aware of have not said that a single dose of doxycycline is okay in children under 8. I think there needs to be some more information so that we can translate those findings from the tooth staining study and apply that to other situations. But at this point, it's not currently recommended. But I think, you can use your clinical judgment, of course. I mean, we wouldn't want children to be getting this over and over. I mean, there's lots of potential exposures to ticks and Lyme disease, and so we wouldn't want this to be overused. But I think it's something that, as an individual clinician in consultation with an individual family, you can consider. But there's not official recommendations, is the bottom line. Let's see. I see some other questions. Okay, so the question is, there are some self-described Lyme specialists. Are there any accreditations one might see to confirm this specialty? So that's a very good question, and no, some practitioners do use the term Lyme literate MD or Lyme specialist, and that is a nebulous term. It actually does not mean that they've gone through any special accreditation or board certification. It doesn't necessarily mean they're trained in infectious disease or anything in particular, so that's more of a term that certain providers use to describe themselves, but there's no official training or validation of those credentials.
Is there another one there?
I don't think so. I saw 2 that were part of the same question.
Okay, great. Anyone else have any other questions?
There are no questions over the phone. You may continue.
Okay, great. Well, Dr. Nelson, I just want to say thank you for a spectacular talk. This was phenomenal, and we really appreciate your time today and leading us with these resources to move forward. Clearly, in Pennsylvania, this is an issue, as you shared. So thank you for being with us today. I did want to tell our participants today that I'd like to acknowledge the Pennsylvania Department of Health, whose financial support of our grant and this program made this possible. For those of you that are interested in obtaining CME, CEU credits, the nurses that attend this program will get a certificate of attendance for 1.5 hours of continuing CME, as well as the physicians as well. This activity has been accredited according to the ACCME through the University of Pittsburgh. And we also have had no disclosures, for this talk today. So again, thank you, Dr. Nelson, and thank you everyone for participating today. And we look forward to talking to you again soon.
Thank you very much, everyone.